This is Dr. Charles Parker, and you're listening to Core Brain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street.
Well, welcome, folks. Dr. Charles Parker here one more time at Core Brain Journal, and we have a very interesting conversation today with Dr. Dean Howell. And Dr. Howell is a very interesting guy. I'm going to do a brief intro. Before that, I'd just like to welcome you, Dean. Dean, thanks for showing up.
Well, thanks for having me on the show, Chuck. I'm glad to be here.
Well, we're looking forward to it. Dr. Howell is an internationally recognized naturopathic physician, primarily well known for being the inventor and developer of NeuroCranial Restructuring. This is what we're going to talk about today, which is touted as the most potent and powerful therapy in physical medicine existing today. Dr. Howell is also the inventor of FaceMax, considered the best facial remodeling alternative to costly facial surgery and cosmetic beautification treatments. So he was born and raised in Everett, Washington. He's out in Washington now. He graduated from Bastyr University with his naturopathic medical degree in 1982. And that was after he completed a mathematics degree from the University of Washington in 1978. That sounds like a stretch, Dean.
Yeah, it also means
mathematics to
medicine.
Yeah. So,
it also means I'm old. So
join the club. So after that brief intro, why don't you tell us a little bit about your personal life, if you don't mind?
Well, when I'm not working and traveling, which if you look at my schedules most of the time, when I'm at my home way out in the country, and I go hiking in the mountains, and I also am a lover of golf, and I read fiction books, and I like some TV shows, and that's about all I've got time for.
Well, you sound like a working guy. Before we actually started, you say you're over in Europe and you're doing presentations all over. It sounds like a very interesting process, and as I said a moment ago, I'm looking forward to talking with you about it. Why don't we kind of start at the beginning? You were doing mathematics, but what actually switched you over not only to looking at naturopathic medicine, but actually going into the kind of practice that you currently have today?
Well, the reason I ended up in natural healing is because I was a chronically ill kid. By the time the rains would come in Seattle area in late October, I would get sick with bronchitis, and it wouldn't go away till it dried out in April. It was like that every year. But every summer, I was raised on a lake, and I was a water skier and a football player, and I had lots of head injuries. I broke my nose. They used to take my helmet and break my nose. I broke my nose kite flying behind a boat, like I was on the kite. And then finally I broke a water ski with my face. And that was the one that, I woke up 5 feet underwater because I'd been unconscious for a while, and swam back up and wanted to ski home. And my driver refused, saying there was too much blood in the water, that he wasn't going to let me do that. And after that, my right nostril didn't work, and I'd always had that chronic illness, and I finally figured out that my lifestyle was behind getting the bronchitis all the time. And I decided to go into naturopathic medical school because I couldn't handle the chemicals that my father was using in his dental office. He wanted me to be a dentist, but I got too sick. I'd go in there and feel horrible. So I would go into naturopathic medicine, and I found out that there was a technique called bilateral nasal specific that could be used to treat nasal breathing problems.
Now stop and say that again, Dean, because myself and our audience, we're not familiar with that term. Say it again, please.
So it's called BNS, bilateral nasal specific, and it dates back to the early 1930s in America. And it was using a small balloon that would be attached to a blood pressure cuff bulb, and then they would slide it through the nostril into the top of the throat, the same way that air goes when you breathe in. Mm-hmm. And it turns out that you have small plates of bone called turbinate or concha bones that subdivide your nostril. So when you put your finger into your nose, your fingertip fits at first, and then it feels like it hits a wall. And you're actually hitting three pairs, well, one on each side, but three bones in each nostril that subdivide the nostril into four little passageways. and they would slide the balloons through those 6 lowest passageways in the 2 nostrils and use that to push the bones of the head back out, sort of like taking a hammer and pounding out dents in a car fender.
Now, let me ask you a question, because I know a little bit about this, and I'm not posing at all right now, but are you talking about the turbinates? And you would go between the turbinates and pull the turbinates out?
No. The balloon would inflate in the nostril and push its way into the top of the throat, and it would push on those turbinate bones and the nasal bones and the septum, and slightly open those sutures, those joints in that part of the face.
I understand now.
Open. And when they open, the connective tissue that's inside is under tension like a spring, and it starts unwinding like a jack-in-the-box springs up. Well, that connective tissue springs out when we open the joint.
Now, I know our listeners don't know what a suture is. You got to say that one too, because I do know what it is, but explain what a suture joint is.
So the sutures sound like they're knitted together, okay? And what they are is those little cracks that you see if you look at a skull. There's these little cracks between the different skull bones, and they'll even in some inaccurate anatomy books say that they are fused together. And very rarely are they fused, but they don't move very easily either. But if you hold onto your temples tightly with the heels of your hands and blow out and hold tight and inhale, you can feel your head bones flexing. Because your head literally gets bigger when you inhale and smaller when you exhale, and the different skull bones actually shift when you chew. And these joints that are moving are often called sutures. And after you've had head injuries like being born, and falling down, and being hit in the face, or car wrecks, sports injuries, or even pulling teeth or doing orthodontia, all of these things cause these skull bones to shift around into different patterns. And as that happens, you're less and less symmetrical, and those joints get more and more contorted and twisted.
Well, that is so interesting. I just saw a patient this morning, and I was really looking forward to this conversation because I had a woman come in. She was the worst TMJ patient I've ever seen, and she really wasn't my patient. She was sent to me by a dentist who specializes in TMJ, and she had so many immune system dysregulation problems, and she'd seen so many people that she was like, I just don't know what to do. And she was difficult because she'd been turned down or treated inadequately so often. It was really hard to form a relationship with her. But her TMJ just radiated over her head all the way down her shoulders and into her chest on a regular basis. You probably see that all the time.
Unfortunately, I see a lot of it. Yeah, and it's outside dentistry. Mm-hmm. They need people like us and the dentist to get them fixed.
See, now that's a very key point. That is an endearing sentence right there, Dean, because what you're saying is we really need to think about working as a team, work comprehensively, cover all the bases. Some of us have some skills, others have others, and we need to figure out how to synchronize what we're doing.
Yeah, and it's a difficult thing to get people to do.
Oh, yeah. There's no question about that. So I won't ask you for the treatment there, but that was very interesting at the balloon, because when I was looking at something else that you had written, the balloon seems to still be a part of your practice in the sense of that very interesting bone out there in the middle, the sphenoid bone.
Right.
Could you tell us a little more about that? Because that's just almost unbelievable, but it sounds so interesting.
Well, when you're going to do cranial manipulation, at first it sounds like it should be kind of like going to the chiropractor or osteopath or somebody to get your back cracked, And it turns out that those sutures are much harder to move than the bones like in your neck and back or popping knuckles in your hands. We can't do that. And so we still can move those bones. So we start moving the bones by sliding them around. That's how we can do it with the craniosacral and craniopathic techniques. But the bone that's hardest to move is right in the middle of the head, and it goes from temple to temple. It makes up part of the back of your eye sockets, It's actually what they call the body of that bone, the sphenoid bone, is behind the nose, pushing right up against the midbrain. And then if you think of that bone as looking like a butterfly or a bat, where the wings make up your temples and the body's behind the nose and eyes, then there's trailing legs that hang down and they go into the roof of the mouth. And that's the pterygoid processes reach all the way into to touch your hard palate. So when I use the small balloon, I'm pushing on those legs, and I can push on different heights of those legs. I can push right at the very top where the two legs come together, in the middle, or in the lower part of that same bone, and that causes the sphenoid bone to wiggle different ways when I inflate the small balloon, and it pushes its way past there. So I can then direct the way that I shift that bone. And then when the joint opens, the connective tissue tension inside, like a spring, has a place to expand, and then the bone shifts. And if I improve the pattern of stability of the overall bone structure, then the body has no reason to revert back to where it used to be, and then we can accumulate this treatment as a long-term change. And what I learned before was how to fix every bone and joint I could, but it made such an unstable change. It was like a house of playing cards. It would blow over, so people would come back a day later or a week later and say, that was a really great treatment, do it again. But now, when we realize that it's all about stability, if we make the body more stable after a treatment than it was prior to the treatment, the body doesn't try to revert back to where it used to be, because it's mainly interested in not falling down and being stable. So if we can improve the symmetry and improve the stability, we can accrue those results like interest on a savings account. And that's how we can do neurocranial restructuring and get results that the other people aren't getting.
That sounds so interesting. Now, let me interrupt, because while you were talking about that,
sure.
I apologize for interrupting, but to clarify, it sounds like what's going on, I'm really looking forward to elaborating on. That's why I'm asking the question. It sounds like you're not only doing those things with the cranial sutures, the sphenoid bone, and all that sort of thing, but you're also saying something about working with the entire foundation of the body below.
Exactly. You can't make local change. The body is integrated and it's comprehensive. You have to address the entire system every time you do physical medicine work, or else it can't last.
So what you're saying, if the sphenoid is out of shape in some way, I'm being very almost silly about it because I really don't know the answer to the question that I'm asking you. But if the sphenoid is out of shape, you could actually see derivatives of that sphenoid maladjustment all the way down into the body in some specific way.
Right. And in fact, more than that, we can't even just blame the sphenoid. If we look at the overall body, what we would like to do if we take different anatomical points, like the collarbones and the corners of the eyes and the kneecaps and so forth, what we would like to do is if we were looking at a person straight on or straight from the side, we would like their body to line up in a perfect grid. But not very many people do, right? You've seen those kind of pictures of people, and they're always looking all twisted. And so then when we do body work, whether it's spinal manipulations or whatever, we're always trying to make the person more symmetrical. Right? That's when we tell people their bones are out of place. That means that they're not in the symmetrical midline position. But what I found was that wasn't enough, because if I put everything back in the midline, and yet when the person was standing there, now they were easier to push around. You know, if I push on their body, they're less stable than they were before I treated them. What happens is that they that treatment is quickly undone, and they revert to their pre-treatment status. With neurocranial restructuring, what we're doing is accumulating treatments that will improve the pattern of gravitational stability and improve the symmetry. And when you're more symmetrical, you function better. And when you're more stable, you retain your benefits. And in that way, by doing sequential treatments over a few months, let's say, then we can get those long-term changes that people want.
So what you were saying so interestingly was the fact that you're really stating the philosophy of what you do, and that is covering the entire organism and dealing with the entire the entire person, I should say the entire organism. But the next thing I want to ask you about is, let's take this discussion into the obvious down to the less obvious applications of neurocranial restructuring. So the obvious ones for me as a medical practitioner would be, for example, headache and traumatic brain injury. Could you tell us a little bit about what kind of results you've had working with traumatic brain injury, for example? We've had a number of people here on Core Brain Journal talking about TBI.
Yeah, well, it's really quite routine to get traumatic brain injury better. The expectation is always that if a person's had a history of stroke or other traumatic brain injuries, that they will get better, because we're going to mechanically change the shape of the box that we keep the brain in. Mm-hmm. So if you think of your brain, it was designed to be in your perfect skull. And it runs hydraulically, so it depends on blood and cerebrospinal fluid to operate. And so it's only when the brain is not being even slightly squeezed that the brain can work perfectly. Well, if you go to a shoe store and you're going to pick out shoes, you try on pair after pair after pair until you find the pair that feels comfortable, and you wiggle your toes and everything's good. Now you found your right shoe. If it's not that, you have to get a custom-made shoe. So your perfect skull is the custom-made shoe. And then what's happening is, after you've had a history of head traumas, is that the clerk is going to jam whatever shoe is convenient onto your foot. So your brain is now housed in whatever shape that your head randomly ended up with after your face collapses from pulling teeth, falling down, accidents, beatings, sport injuries, or even PTSD type of horrible experiences. All of those cause your skull bones to shift, and then your brain fits less and less well, and it starts malfunctioning more.
So those folks returning from the war, for example, who've had a concussive event, even if they haven't clearly, they may have had some brain injury with the concussion, of course, but they may not look like they had a concussive event. But those folks that are more on the nuance side of a TBI, wondering what's going on with them, wondering why their emotions are all over the place, wondering why they can't get themselves together cognitively, could really benefit from actually moving some of the cranial sutures around.
Yeah, I worked with the Marine Corps in 2010 in Oceanside, California, and they gave me 6 Afghani war vets who all were waiting to be discharged because their PTSD, chronic headaches, insomnia, they were just not able to function as soldiers anymore. And I worked on those 6, and I said I would do 6 4-day treatment series. So I would do 4 days once a month. And after 4 months, so they'd had 16 treatments, the soldiers got together and voted to discontinue treatment. They went to the commanding officer and told him, and he said, well, I thought that this Dr. Howell's treatment sounded like a lot of crap. And they said, well, no, actually, we're all better than before we joined the Marine Corps.
Oh, my God.
And we think that we want to stop because there's 10,000 other guys, literally 10,000 other guys in the barracks just in Camp Pendleton waiting to be discharged. We want you to take some more, take another 6 of them and go back and have him treat those as well. And the commander's decision was, he says, oh, the heck with it, I'm just pulling the plug on the program.
Oh, my God.
And I had 100% success.
Oh, my gosh. Now, it has to do with belief, doesn't it? Forget reality. We're going to go with belief.
Yeah, don't confuse me with the facts. I've made my mind up.
Yeah, right. That is so commonplace today, and because it sounds so unconventional, that story alone, it sounds so unconventional. But when you have a consensus of 6 guys saying, "Look, I'm done. Let's get these other guys in," that's an important vote right there. That's a very darn important vote.
And it also shows you that they actually didn't have brain trauma. They only had brain pinching because of the severity. Well, they all of them were in trucks that exploded and things. near trucks exploded nearby, but it was mainly what they saw that created their PTSD. And these are nice people. If you're not a psychopath and you see someone blow up, or someone that gets stabbed with a knife or something, you're not right. It's only psychopaths that are fine watching those kinds of things. They're even finding that drone operators are having PTSD now.
Is that right? I hadn't heard that. That's
just because of what they know that they're doing. When they blow up a building and people die, the drone operators are getting PTSD because they're nice people.
And they know what they did.
And I guarantee you the Marines that I worked on were some of the nicest guys. They were so altruistic. And that's why it hit them so hard. See, if they had been more brutal, they wouldn't have been upset by those things. They'd still been over in Afghanistan. Well, maybe not by now. That was 4 years ago, or 6 years ago. But the point is that it's the impact on your nervous system that makes your connective tissues slightly tighten, and then your bones scoot a little bit, and then they stabilize in that new pattern, and now your brain's a different shape, and it doesn't work the same anymore.
See, that is so interesting. Now, listeners, I'm going to just mention to you real quickly, we're going to have a download. It's going to be corebrainjournal.com/018. This is Dean's time here. And 018 download is going to be the download. So it's /018 download, all one word. And we're going to have a download for you. Dean and I were talking about which way it's going to go. And it could be a book. It could be a PDF. He's rewriting his book. Tell us a little bit about that before we go on to this next clinical part. What's the book that you're writing?
Well, they want to rename it. I used to call it, I have two books. And one book is about NeuroCranial Restructuring, and it's called, I think the earlier name was Keep Your Head On Straight. Mm-hmm. And the publisher says that really sucks as a name. So
and that closes that one down.
Anyhow, so we're redoing that. We're trying to collect newer testimonials and photos and things. And so that's a good book. And it should be done in 3 or 4 months again, I think, maybe sooner. And then the other book is based on my experiences around cancer, because my second wife died of cancer 4 years ago. And I didn't know much about cancer, and I learned a lot, and I wrote a book about that. Oh. And there's a lot of shocking information, but that would be a different show.
So let me stop real quickly and ask the specific name of the book, because you kind of went over it quickly, and I want to make sure I got it. And I think is that the one you sent me the link to?
So, yeah, it's called, oh no, I was wrong. It's called Unleash Your Structural Power.
Okay.
And that's still available under that name, okay. Unleash Your Structural Power.
All right. So there we go. So let's, we're having a little bit of recording problems here. We're going to keep cooking along. What I want to do is make sure, thank you, I'll put that in the show notes, because I want to make sure our listeners get to hear you more on the clinical side, because that's what they're interested in. Tell us a little more about these edgy things, quote unquote edgy things, if you will, that you're also into regarding the next level. I mean, headaches are pretty obviously related to traumatic brain injury. But you also talked about actually moods, ADHD, depression, anxiety. That's close to where a lot of people are with this program. So tell us a little bit about that and what you're doing.
Okay, well, we were just talking about the brain and how the brain's shape is changed slightly when the bones move. That includes the areas in the midbrain area, which is right behind your nose and eyes. That's where your basic moods are created. So what we find is that people that are chronically anxious or chronically depressed or chronically hyperactive or dyslexic, when we start changing their skull shapes, then their brain changes shape and their moods change too. Mm. And then if it's the right behind the forehead area, if that area decompresses, then we find that people suddenly their foggy thinking and the inability to process very much information goes away. I was literally just the person I saw before this interview is a pilot that was in he was in Fiji or someplace, or Australia, and a bouncer, thinking that he was drunk, punched him in the head, and he can't fly a plane because he can't process multiple data information. And he's in his first series, and already that problem's going away. We're already discussing how he's going to be able to go back to flying again and trying to prove to the medical people that he's going to be that much more functional.
Wow, that's fantastic.
So we can change those moods, and that's a big difference. And I work with dyslexics and people with, there's kids that you talk with them and they seem smart, and then their grades are bad, and they're looking out the window and watching the birds. And when I start working with those kids, they start finding the classroom more interesting again, and they start watching, and then their grades go up 1-2 letter grades, in a few months.
Well, that's so encouraging, and I remember looking at your website before all this. I was looking at it last night. You've trained a number of people, so you have how many people do you actually have on your roll there on the website if someone wanted to get involved?
I think there's 12 or 15 that are on there, and they represent less than 1/10 of the people that I've trained.
Oh, so that's interesting. So
because a lot of the people that I've trained won't follow the protocols very exactly. They would rather shorten them so they can do more volume, and I have a big problem with those other people.
I got you.
Because,
yeah,
there's a certain point where you have to choose results over money.
Yeah.
So anyhow, there's like 135 of those other guys out there, and there's 15 that are doing it the way they're supposed to.
Well, we'll look forward to it. I'll have that link, folks, on the show notes back on Core Brain Journal. So as we wind up, now we've gone from the obviously useful, and I say obviously because to me it's obvious. It may not be obvious to others, but when you're really talking about physical challenges, deformity, moods. I was interested to see on your website that you were actually talking, and we talked about it in the intro very quickly, about FaceMax. It sounded to me almost cosmetic. Could you tell us a little bit about that?
So the FaceMax is an outgrowth of my practice because people that have teeth pulled realize that their face collapses. If you want to see an extreme case, you might have seen these posters of a silly-looking old man who has no teeth, who takes his lower lip and puts it over his nose. Okay, have you ever seen a picture like that?
No, I haven't.
Anyway,
I think I'm going to avoid it if it comes up.
But the idea here is that when your teeth get pulled out of your mouth, your face collapses. And this has been written about in dentistry books for 200 years. They charted out exactly the way the face collapses as you pull teeth. Well, I had a guy that I was seeing, and he was like 25, and he knew that when he was 15, he'd been the smartest kid in his junior high. He was 6'4". He was the tallest kid in the school in England where he went to school, and he was the basketball player. He loved playing golf. He was very athletic, high grades. And they said, gee, you don't have enough room for your teeth. And that's a whole discussion point because that's actually more philosophical than it sounds. And they said, we're going to pull these 4 bicuspids. They pulled the 4 bicuspids, and within 6 months, he was having neck and low back pain to where it hurt to run up and down a basketball court. And then he noticed his grades started dropping, and when he turned 18, he went off to college, university they call it there, and he was unable to finish the first term of school because he couldn't memorize anything. Remember, he'd been the smartest kid in his junior high school. So he spent the next 7 years trying to figure out what to do, and he tried the parasite cleanses and the candida diets, and he ended up in a colonic clinic once, and he read an article by a dentist from London who was working with people who had had facial collapse from teeth being removed. He switched to him, and he didn't move him enough. And then the two of them reached out and found me and persuaded me to start coming to England to work on their patients. Wow. And they were working with a modified cricket helmet where they used rubber bands in the mask of the cricket helmet to a retainer that they had in the roof of the mouth, and they were pulling the face out. And it didn't work. And they said, I don't know why it doesn't work, but it doesn't work. And I said, let me see how you have it set up. And I found out that there was a number of things that I disagreed with. And so I started using these modified helmets, and they started working. And meanwhile, the dentist who had first thought of those things, his name is Mohammed Amir, he washed his hands and refused to be part of the project anymore. And so we've made it into the FaceMax, and we can bring people forward 3 to 5 millimeters a year. We can bring their whole face out, and it only takes less than 15 minutes a day. And as that happens, your face comes out, so your skin gets tighter and tighter, because the reason that we get wrinkles is because of bones collapsing and not stretching the skin. Kind of like if you put up your curtain rods wrong, you get weird looking drapes, or if you set up an old-fashioned tent the wrong way, it's got wrinkles and creases.
Yeah.
So as your face comes out, you get rid of the wrinkles and lines, and as we do the NCR, we make the eye socket symmetrical, and we change the bridge of the nose and cheekbones to where they're nice as well. And then on top of that, the brain's inside, so we get improvements in brain function as well. The moods even out, the creativity improves, and so forth as well. So for the people that have had 4 teeth pulled, like wisdom teeth, it can be very helpful. By the time people have 8 teeth pulled, and there's a shocking number of adults that are missing a fourth of their teeth, bicuspids and wisdom teeth being pulled, then we can help them a lot with these helmet devices to pull their faces forward again. It's a wonderful device.
That's amazing. And we're running out of time, enjoying this conversation so much, and we had that little glitch, listeners, where the audio went out for a second. I just want to wrap this up for just one quick, brief moment by asking you about cosmetics. You mentioned offline that you've even done this really cosmetically, almost like plastic surgery, with models. Tell us a little bit about that.
Well, this is what I was doing about 20 years ago, a little over 20 years ago. I decided I was going to focus on just making this work big by getting rid of wrinkles and changing the shape of eyes. And a couple modeling agents in Seattle area started sending me all of their models, because the more symmetrical a model is, the more work she books. Especially if the two sides of her face are different, then they can't take pictures of her very easily because she'll look like a different face. The classic example of that is Drew Barrymore. And if you see Drew Barrymore, they always shoot her from the same side of her face. And that's because her face is so crooked that when they shoot from the other side, you wouldn't recognize her. Anyhow, so, that's what we can then do, is we can start working with people to get them more symmetrical. And I thought that was great, and it was really working. And then these women just drove me crazy. I don't know. I kind of think my eye is not quite high enough yet. Maybe we should go back in the room and we should do some more treatments now. I said, I've already worked on your allocated time. You're done for the day. You have to come back next week. But I want more eye stuff right now, and they want to do surgery on me right away. I finally got to a point where I said, no, I'm just going to look for headaches and sinusitis. And
stay with the easy stuff, right? Yeah, I mean, it's funny. When you get over into nuance, it gets to be more and more difficult. And appearances are always, pardon me, so subjective. So I just swallowed down the wrong pipe. I was laughing so hard on that one. But the bottom line here is you have a wide variety of applications, Dean, that you're talking about that are really quite interesting. I think for me and for our listeners, the most interesting are the really medical issues: TBI, headache, moods, even ADD. Very, very interesting. And before we go, please tell us how we can connect with you, where you'd like to send us to learn more about this, connect with you, and get involved.
Okay. Well, if you can spell my name is DeanHowell, and you will find drdeanhowell.com. That's my primary website. And if you put in Dr. Dean Howell again in YouTube, there's a pretty good number of videos posted now, and I made 30 or 45 more, and perhaps they're being posted this week. I mean, they've been done for a while. And then there's my books. The one book that you can still get on Amazon that's going to be updated in the next couple months. It'll be an ebook when it comes back out. But find me on YouTube, find me on the internet, and then podcasts like yours.
Well, thank you very much. We're going to. I'll just mention that one more time. I think, my sense of staying on top of this thing, Dean, would really to ask your team to give us a PDF. Then it could be faster. And it's very generous of you to offer the book. And I know we're just making a kind of a unilateral decision here. People might like the drawing for the book, but it's not going to be done for a while. And we could get you done. I mean, we could get this download the PDF in the next 2 weeks. So,
for sure.
If we have people who sign up,
we'll get that done soon.
Yeah, that'd be great.
Yeah.
So, thank you so much, Dean, for taking the time. It's been terribly interesting. I think you've shed some light on a whole different treatment approach that really is realistically available, and it may not be for everybody for every small thing, but you really did mention a wide variety of intervention possibilities to a trained practitioner.
Absolutely.
So thank you very much, Dean. I appreciate you taking the time, and we'll look forward to having you back someday.
Okay, Chuck, I'd be happy to come back again.
Thanks for listening to Core Brain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at corebrainjournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.